I am thrilled to introduce our next speaker. Dr. Willow Sheehan is a dear friend and a close colleague who works as a nurse practitioner within the Department of Medical Genetics here at Shodair Children's Hospital in Helena, Montana. For her complete bio, please reference the attendee website. Today, she will be discussing nurse practitioners and genetics, current state and future considerations. A reminder to please submit questions through the Q&A tab. Please reference your screen for CEU accreditation and disclosure statements, as well as learning objectives. For additional information, please visit the CEU tab in the attendee website. Dr. Sheehan, when you're ready, the floor is yours.
Great. Well, thank you so much for that lovely introduction, Jacqueline. And just to be certain, is everyone seeing this, this slide here? Great. Okay, great. Well, I'm just very excited to be presenting on this topic today. Like many nurse practitioners, I have had relatively limited exposure to medical genetics in my graduate training. However, I have always been interested in genetics and genomics and was excited to enter this career path. So after 3 years of practice in general genetics clinic, I believe that nurse practitioners hold the potential to expand access to genetic care, and that medical genetics practice can be a fulfilling career choice for some NPs. But like everything in genetics and genomics, this is a growing and evolving realm of practice that warrants some intentional consideration. So with that, I'll begin my talk today. Let's see. So in terms of disclosures, I am clinical faculty for the DNP program at MSU. However, I don't plan to discuss MSU's DNP program today, so really no disclosures. I am planning to cover a lot of material today, so this will be kind of a surface level discussion of the topics at hand, but I'm happy to go into further detail during the Q&A. And also I've provided my contact information, so if you'd like to reach out to discuss anything further, I'm happy to engage in that conversation. So let's start out just by providing some general information regarding nurse practitioners, their training, and their governing bodies. The first NP program was developed in 1965 through the University of Colorado with the intention of providing care to underserved populations. And of course, since then, the role of NP and our education has evolved. Today, an NP is an advanced practice member of the healthcare team, trained to evaluate, diagnose, treat, and manage acute and chronic health conditions with an emphasis on disease prevention and health maintenance. We're first trained as registered nurses, and as such, we can pursue any area of registered nursing practice that interests us. And many of us have years of experience in various care settings before pursuing graduate education. Graduate education can either be a master's or a doctorate degree of nursing practice, including clinical rotations within a focused area of primary care. There are a couple things to keep in mind here, though. So first, not all graduate programs require experience as a registered nurse among the entrance criteria. And then second, our scope of practice is limited somewhat by the education program we choose. For example, a nurse practitioner trained in pediatrics cannot see adults. Or further, there are some limitations to the acuity of patients we can see based on our specific education program. And then upon completion of our graduate level training, we then pursue national board certification and state licensure like many healthcare clinicians. And as you can see, the bulk of us are trained as family nurse practitioners. So let's talk a little bit about NP scope of practice. And I will tell you, this is where things can get a little murky. Let's start out with these two documents in the upper right of the screen. So the consensus model for APRN regulation published in 2008, and then a subsequent population-focused nurse practitioner competencies document published in 2013. So these documents were among the first of their kind, and their intention is to standardize NP preparation and certification across the nation. So recognize that our standards of education and licensure and accreditation are relatively new, and to some extent still evolving, especially when it comes to specialty practice. Our competencies document for nurse practitioner education is quite generalized, and with the potential for differences in preparation from program to program. And genetics and genomics is not considered a core competency of our training. So just a couple of things to keep in mind as you're considering perhaps integrating a nurse practitioner into your practice. Additionally, the state-based laws and regulations governing our practice are also quite varied. So the colorful map that you see there demonstrates some key divisions in state laws affecting NP practice. In the green states, NPs have full practice authority, whereas in the yellow and red states, NP practice requires physician oversight or a practice is restricted in some manner. So despite the fact that we all sit for the same board exams, our scope is different from state to state. In Montana, the laws governing our scope of practice are quite general. And as such, it can become really difficult to interpret our state laws and regulatory documents as they relate to practice in a specialty field like genetics, especially when our training really is quite limited. So around this, the Montana State Board of Nursing has created a scope of practice decision-making framework for NPs, and I suspect other states have a similar tool. So I've included an excerpt of this tool so you can get a sense of how our regulatory documents and state laws might be practically applied as they pertain to NP practice and genetics. This portion of the algorithm that I've included here is looking to ensure that that the NP is adequately supported by her facility, has adequate knowledge and competency in the area that she's practicing, and has the resources needed to function in that specific subspecialty role. So documents like this can really help a team to determine what needs to be in place to support an NP practice in a genetic setting in their state. So in some instances of NP subspecialty practice, there are board certifications available, which really serve to legitimize the NP's practice in that setting. This is not true for NPs in genetics and is really a hot topic of discussion for advanced practice providers in the field. Of note, there is a genetics fellowship program for NPs through Vanderbilt. This program is specifically for master's prepared NPs looking to get their doctorate and includes both didactic genetics education and fellowship training in a genetics clinic, which is fabulous. Although I think this is truly the only certification program of its kind, and so can be pretty limiting in terms of how many students are accepted each year and that you have to live kind of by their school. There's also a portfolio-based certification for NPs in genetics through ISON, although this does not include a test of competency, but is rather an experience-based certification program. And I think I speak for a lot of nurse practitioners in the field of genetics when I say that a lot of us would prefer an opportunity to demonstrate our competency through a test-based certification. And I'm hopeful that we have more to come on that in the coming years. So with all of this in mind, I'm sure you may be thinking at this point, like, why are we even talking about NPs in the field of genetics? And it's a good question, kind of given the limitations of our training. Firstly, I would say that, NPs are awesome. Look at all those A+ traits up there, but perhaps this is a bit of a biased sentiment. And so objectively, I think it's reasonable to say that we add diversity in our approach to patient care. But again, I don't really think that's the whole picture here either. So Interestingly, NPs have actually been working in the field of genetics for much longer than you may think. I recently met an NP who started in genetics at Cincinnati Children's Hospital 27 years ago. So really, we've been in this field for nearly 30 years. And the reasoning then for her entering that field was the same as it is now. And it's really increasing access to care. So data from the American Board of Medical Geneticists suggests that there are only about 1.9 clinical geneticists per million people in the United States. And while we don't really have good data to tell us how many geneticists are needed to serve 1 million people, it's generally understood that 1.9 per million is not enough to serve our nation's genetics care needs. So whether you live in a frontier community like our team in Montana or an urban community, undoubtedly there are patient populations in need of genetics care that are not being served. So when you look at the charts here, you can see that from a sheer number standpoint, NPs have the capacity to fill some care gaps in the field of genetics. So really the most important barrier to NPs practicing in genetics and genomics is their lack of knowledge and experience in the field. But you may recall, though, that the first NP program was created with the intention to expand access to primary care for underserved populations. And at that time, the barrier was the same as it is now. And I think it can be overcome in a similar manner through formal and informal education. And really, there are already quite a few of us pioneering this practice. So as of right now, we don't have a lot of published data again on about NPs in the field of genetics. So the next few slides present information from the 2022 Clinical Genetics Advanced Practice Providers Conference, or CGAP for short. This conference is excellent. It was started in 2019, and it is the only one of its kind that it is intended to serve the learning needs of NPs and physician assistants in the field of genetics. I've included attendee data here with permission from the conference director, Stephanie Oford, with the Medical College of Wisconsin. And just keep in mind as we review these slides that they're based on only 44 conference attendees. So the data may not be widely applicable, but I think is the most relevant information we have. This first one shows the states where conference attendees were practicing. And I was most impressed to see that NPs are becoming part of the genetics team all over the country. And there really wasn't a clear regional bias. In this next slide, so the top left chart here speaks to years working in the field of genetics. And you can see that we are, as a group, relatively new to the field, most of us having 3 to 5 years of experience being kind of typical. And but also note that there were some conference attendees with over 15 years of experience. So there is some longevity in this career path for us as well. Roughly half, and I'm referring to the chart on the bottom there, so roughly half of the attendees saw only metabolic patients, while roughly a quarter saw general genetics patients, and a quarter saw both metabolic and general genetics patients. So it does seem, at least from this conference, that NPs and PAs are more extensively utilized in metabolic practices. And I think, I'm guessing that this is in part because caring for metabolic patients in many ways is very protocolized. So kind of an easy place to jump into genetics care. When attendees were asked if they felt supported, the bulk of them replied in the affirmative, which is great to see, just recognizing that on-the-job training and support is absolutely necessary for success in the role of genetics NP. The second chart here shows replies to the question, who do you see patients with in your clinic? Most saw patients with either a genetic counselor, a dietitian, or a registered nurse on their team, which I think is pretty typical of most genetic providers that I'm familiar with. let's see. So let's switch gears here a little bit and talk about how this all works to integrate an NP into a genetics practice. And so again, just recognizing we don't have a lot of published data on this. So most of these slides are based on my own personal experience and conversation with NP colleagues in the field. Certainly, there are no journal articles using exclusively tree analogies to describe these models. So you're getting a truly unique experience here today. The first practice model I'd like to discuss is the Aspen model. So many of us in the Mountain States probably are familiar with these scenes. So consider how aspen trees are really easy to spot in a sea of other trees. So whether you're looking at them from across the field or right up close at the bark, you know which ones are the aspens by their beautiful foliage and their white bark with black spots. And so in this model, the nurse practitioner is integrated into the clinic by seeing only a very specific and well-defined genetic population with a clear diagnosis that's easy to spot, just like the aspen trees. It's easy for the whole team to tell which patient should be assigned to the NP. And this model works really well in several ways. So it makes it easy for the NP to learn what she needs to know to effectively care for the patient population at hand and stay up to date in that knowledge. And then the NP also can quickly gain confidence in her role and really require relatively limited support from the team over time. So essentially, it's a quick and easy way to increase the clinic's patient capacity with the support of an NP team member. And like I said, this model works really well in some settings. However, without a little forethought and ingenuity, the Aspen model can kind of devolve into what I call the thorn model. And as its name sounds, the thorn model is, well, a little thorny. So why does the Aspen model sometimes become problematic? Well, here are a couple scenarios. So sometimes an NP is integrated into a clinical practice to care for a specific population, but that population can perhaps be very time-consuming to care for, or perhaps emotionally taxing for one reason or another. And then that is the only patient population that they see day in and day out. So in this case, there can be a really high rate of burnout for the NP and kind of some poor job satisfaction. Alternatively, an NP is integrated into a clinical practice and assigned a patient population that is mostly very easy or straightforward to care for. So this is great for the NP, but it can make it so that the MDs on the clinical team are then left to see the most complicated patients only, and it actually causes an increased workload for that group. And then furthermore, over time, the NP in this scenario may become kind of bored or lose job satisfaction. So in summary, the Aspen model can work really well, but you want to be aware of these kind of thorny pitfalls and plan accordingly. The next model I'd like to discuss, I call the hand-picked model. And there is actually a published triage algorithm for this model developed by Williams and LeBlanc, so a genetic counselor and an NP. And you know, their model is differently titled in their paper, but it's the same really. So the hand-picked model is a scenario in which the NPs see general genetics patients, but those patients meet a very specific set of criteria, and that criteria is often applied in the triage process. So this may include both patients with a diagnosis and those presenting for a diagnostic evaluation. And as a simplified example, so this might look like that the NP may see any patient with intellectual disability or global delays, as long as they don't also have seizures or regression, for example, or the NP may see any patient with early onset hearing loss, as long as there are no other organ system manifestations. Like the Aspen model, this is beneficial in that the NP can be more focused in her learning and easily gain confidence in caring for a less complex subset of patients. This works really well in larger institutions that serve larger populations, where they can have more patients to select from and more patients that meet these sort of specific criteria. We did briefly try this model in our clinic and actually found it was quite difficult for us to isolate the appropriate set of patients. We found that even with strict adherence to a triage algorithm, we weren't always successful at handpicking those patients for the NP. And then the other kind of downfall is that it can create a situation in which an NP is very accustomed to seeing uncomplicated patients and then fails to recognize features concerning for a more severe or complicated disease state. So despite the fact that an NP can gain a fair amount of independence in a short period of time with this model, it does still require some oversight from her ND and GC colleagues. It is also really important to just have a well-planned and consistent triage approach when using this model. And then, of course, last but not least, I want to present to you the aptly named Willow model. You may know that willows are a diverse species. They grow in anything from Arctic to temperate climates. They have a broad network of roots that increase their access to water and nutrients that they need to grow and be successful. I mean, I could go on and on. This is my namesake, but in short, the Willow model is one in which the NP sees a diverse group of straightforward and complex patients with various indications for referral. In order to be successful in this model, it is really important that the NP receives ongoing education, support, and mentorship, which acts as that broad network of roots to support her practice. The goal in this model is to gain increasing autonomy of practice over time and with experience, but still working really closely within a team. This model is beneficial in small practice settings, covering a diverse group of patients, but a small population. It requires no triage algorithm. It fosters a culture of teamwork, and I think it can be really fulfilling both for the NPs and for her mentors. The downside is that it can be a big investment of time and money upfront. From experience, it can be a painfully steep learning curve for the NP, and longevity of the NP in her role is really critical in making this model successful, given that there is so much initial investment in the NP's training. And then finally, this model does not work unless the team is committed to educating and supporting the NP as she learns her role. So this is the model I have the most personal experience with. And I'd like to tell you a little bit about how this model has worked for us at Shodair Genetics Clinic in Montana. So a little bit of information about our clinic. So we are the only genetics clinic and lab serving the state of Montana. We serve through a mix of local clinics, outreach clinics, telehealth clinics. And to kind of put this in perspective so you understand, so Montana is the fourth largest state in the nation. The bulk of the state is considered a frontier for access to healthcare, and the population is roughly 1.1 million. We have 7 American Indian reservations, and then we also have Amish and Hutterite colonies as well. And as such, we are tasked to serve not only these populations, but also to accommodate the wide open spaces of our state. We offer a host of clinic and lab services and run the metabolic newborn screening follow-up program for the state. And before I started in 2019, our medical geneticist was the only one serving the state and was also functioning as our medical and lab director. So we also had a locums provider doing a few clinics per quarter, but our team really needed help serving this population in just this huge state. They had incredible difficulty recruiting a medical geneticist and ultimately decided to try recruiting and training NPs in the role of genetics clinician. And I had the great fortune to stumble upon this opportunity and be invited to join our team. And it's just been an incredible challenge learning this role, but also just super rewarding. So here's how we made this work for us. So these guys are just an amazing team, and they canceled all of their clinics for a whole month and essentially created a crash course in genetics and genomics. They answered a bazillion questions and were just incredibly gracious. The following couple months after that, we did a combination of shadowing our clinics with our medical geneticist, and then co-leading visits, leading visits with close oversight. For a while, like I said, we followed the handpicked model, although this was a little problematic for us. And then we kind of just grew into seeing any patient referred for general genetics in concert with a genetic counselor, and then with our medical geneticist available during the visit for questions and support. And then ultimately over time, I grew more and more capable of seeing patients without direct support during the visit from our medical geneticist. For a period of time during the pandemic, I saw patients basically on my own without a genetic counselor, which also an incredible learning experience and opportunity to enrich my skills, although one I hope not to revisit. I really enjoy working with my genetic counselor colleagues. And so, you know, over a little over 3 years into this role, our medical geneticist continues to be available for support in prepping cases and sometimes discussing cases after the visit. He still reviews and co-signs all my notes. And I think this kind of sounds like a lot when I say it out loud, but what I would say is that I think the burden of my training for our medical geneticist has become less and less over the years, allowing our medical geneticist to devote more time to his other responsibilities. And then the other thing I would say is that the GCs on our team continue to just be an incredible resource, generously share their knowledge and expertise. And also, like, it's GC Recognition Day, so a big shout out to the GCs. They just have really been critical to my success in this role. I've also found excellent guidance from our molecular and cytotechs, neuropsychologist, our metabolic dietitian. So really, it just has been an incredible network of support, which has afforded me the ability to grow strong in my role and keep growing. But I'm sure, you know, you're wondering, like, yes, this is great for you, Willow, but what's in it for Shodair Genetics, clinic and lab? What's in it for the patients of Montana? And so what I would say is that I think this has been a mutually beneficial change for us. We have seen a 61% increase in our patient numbers when comparing the months prior to my start and the first 6 months of 2022. Additionally, we've added some out-of-state contract clinics, which are another source of revenue for our team, and not reflected in these patient numbers that I present here. And then our laboratory's molecular studies have also increased by about 66%. And we've updated testing platforms, added lab service lines, including whole exome analysis. And I think all of this has been made possible, at least in part, by our medical geneticists having a little more time to dedicate to the lab. And while I certainly can't take credit for this, our department continues to grow. We've recruited and hired another medical geneticist and another nurse practitioner. Our genetic counseling service line has also grown, and we've added 2 new genetic counselors to our team as well. I think another important part of all this is that we've really continued this culture of formal and informal mentorship and teamwork. And I think we're really like a lot stronger team because of it. So what are the key takeaway messages for those of you interested in integrating an NP into your clinic? So it's really important to have an expert clinician or a whole team who is excited about and committed to training and mentoring the NP. You want to be diligent in your interviewing process and know what you're looking for in the candidate. While prior experience in genetics or a related field is ideal, personality is also super important. And you want to just be sure that you're getting a good fit with your team and so that you have that longevity in your clinic. And then regardless of the model you choose, just know that an NP without prior training or experience in genetics will need dedicated time for education. There are lots of different ways to provide this, but you just want to be sure that you have a clear plan ahead of time before that NP gets started in her role. Again, mentorship can come in many shapes and sizes, but it'll be critical for that NP to have both formal and informal mentoring to be successful in the role as well. And then you also want to kind of consider how best to support the NP as she gains clinical experience with different populations. And thank you for your attention today. That's all I have for you. I'm glad to take questions. I have a couple reference slides here as well. And I'll stop sharing.
Willow, thank you so much. That was such a great talk. And as your colleague, I just can't say enough how wonderful it is to work with you. We've had some really good questions come in, so I might just jump to those. First up, is the CGAP conference available to RNs who might be interested in pursuing an APRN career path, or would you already have to be an APRN to attend?
So the APRN who we hired in our clinic recently was with us as an RN prior to taking on that role. And she did attend that CGAP conference kind of 1 year before taking on that APRN role and had no problem doing that. And I think it was a really, really good sort of just jump start to her education, and also just kind of knowing more about what it's like to practice as an APP in this field.
Great, thank you. Next up, this is such a great topic. Can you compare and contrast the models of NP in genetics and the use of other supportive roles such as a genetic assistant?
You know, I have never worked with a genetics assistant, and I don't have a lot of personal experience in terms of like how that role is integrated. Although what I would say is that like it's never one size fits all, right? So we have this really unique rural clinic, and really have sort of had to invent this model like as we go. To some degree. I mean, certainly we had a lot of things in place ahead of me starting it. And so what I would just say is that it definitely takes some forethought to integrate a new team member into the team. And there's probably some other resources that are better qualified to answer that question.
Oh, I think that was great. The next one, do you know if there are any data regarding patient and/or provider satisfaction working with NPs in genetics?
So there is very little data about NPs in genetics. I was not able to locate patient satisfaction data. What I would say, though, is that time and time again in the primary care realm, nurse practitioners are seen as well liked by patients and feel that they get good care from nurse practitioners. So it would be surprising to me if that didn't translate over to the genetics realm, but we just don't have that sort of specific subspecialty data at this point.
Perfect. And I would agree, just based on my clinical experience, that patients have seemed very pleased with the service. Next one, I love the commitment to expanding access in genetics. Within the rare community, it's quite difficult to reach providers familiar with rare care and follow-up. Would you see those patients with an MD or possibly with both, or how might that work?
Yeah, so what I would say is that I do diagnose and see patients with rare conditions, and when I'm in the visit with those patients, it's like Jacqueline and myself kind of co-leading that visit together. However, that's not really the full picture, because when we do have those rare diseases, we're often very closely consulting with our medical geneticist, occasionally consulting our metabolic colleagues regionally. And so while, yes, I do see those patients independently, I would say that my practice is also very well supported by my MD colleagues.
Perfect. Do you have recommended resources for NPs currently new to the field of genetics wanting to connect to other NPs in addition to CGAP?
I think CGAP is probably the best bet at this point. They do have a listserv, so kind of a list of advanced practice providers that you can email questions out to. And if you're an NP in the field of genetics and you're not involved with that listserv, please email me and I'll get you hooked in with that group.
Great. Does our clinic have data regarding the decrease in appointment wait time once NP option became available?
I don't know the answer to that question, and perhaps Jacqueline, you do. I know you're involved in that piece.
I don't think formally. I think we could get it though, and we could certainly share it. If you'd be willing to reach out to us, we could probably put that together. Definitely.
And I would say, like, anecdotally, I feel like there's been a huge decrease in wait time, but I don't know for certain.
Yeah, agreed. Next one, NPs versus genetics nurses in general. Any comments on other nurses who aren't NPs?
So I think the question is asking about RNs integrated onto the genetics team. Would you say? Yeah.
That's why I'm reading it. Yeah.
Yeah. So like I said, we did have an RN on our team prior to her becoming a nurse practitioner. And I feel like her role has been just really excellent in the realm of the newborn screening follow-up program. And we partner with Colorado Children's for our metabolic services to serve our metabolic patients in the state. And she has just absolutely taken over that clinic and just made it flourish in that role. And so I think, you know, the same idea is there, that certainly RNs can be an incredible addition to the genetics team, but it just is sort of like, how do you want to integrate them? And that they will require some additional training in order to be successful in that role.
Perfect. Another question, do you have any suggestions for retention of NPs in genetics? A culture of support and education and a manageable number of patients, but any other ideas? This has been a huge issue for our division after devoting a lot of time to training NPs.
Mm-hmm. So one thing that I would say, well, certainly I absolutely love working with this team, and I don't think my answer would be different if there were, you know, other genetic clinics that I could go work for. But what I would say is that for me, like, I am really dedicated to serving the patients of Montana. I was born and raised here. My whole family is here. I'm, you know, have a family property that I'm really engaged in maintaining. So I think that one way that you may consider longevity in a clinic is being sure that the candidate has an investment in the community that you're serving, and wants to be in your geographic location long term. I think that's something that's hard to elicit in interviews, but might be something that makes it possible for you to kind of maintain that NP in addition to all the other things that we talked about.
Great. And do you see NPs bridging the gap with being able to see rural patients sooner rather than later as telehealth becomes more available?
Yes, 100%. So when the COVID pandemic hit, we went fully to telehealth for quite some time. And that, as many of you, I'm sure, are aware of, doing genetics clinics over telehealth is not ideal, and it can be really, really challenging. However, I believe that there was a proportion of rural underserved patients despite the fact that we have all these outreach clinics that just weren't being served because perhaps they didn't have the financial resources to, drive the 4 hours to the outreach clinic instead of the 10 hours to our local clinic. And I think we started seeing those populations on our caseload once the COVID pandemic hit, and have really intend to maintain this telehealth option so that we can continue to serve those populations. Again, it's not ideal. I really would prefer to see some of these people in person so I can do a good dysmorphology evaluation and get a better understanding of their neurodevelopmental presentation. But if we can just kind of get them hooked in and start the testing process, often we can find a way to make it possible to get those exams that we need to get. And it's critical.
Perfect. I think we have time maybe for one more quick question. Have you heard of other advanced practice providers such as PAs serving in roles to expand accessibility?
Yes, absolutely. So in particular, there are a couple PA colleagues that I really look up to who have a background in laboratory sciences, and so absolutely PAs are also filling that gap and doing an excellent job.
Great. Well, thank you again.